Hello, everyone. This is Joanne Tremblay from Plymouth Medical. I hope you're doing well. Thank you so much for joining us today for our aesthetic PRP comparison webinar. We're very, very excited to be here today and to have you join us. Plymouth Medical is a company that's been around the regenerative space for quite some time now, predominantly in orthopedics and pain management, but we've made some significant inroads in regenerative aesthetics, and we're very proud to have put together this experiment on October 4th, where we took the blood of one patient, and we took about 150 ml of blood from this one patient, Dr. Soni, who graciously offered us his blood, and we basically processed his blood across different PRP platforms that are available on the aesthetic market. And we're very, very excited to be presenting the results of that analysis today. So basically, we processed all of the different PRP systems per the manufacturer's IFUs in the manufacturer's centrifuges. And what we did is we took samples of the blood in these sort of red top tubes and ran it through our hematology analyzer. So our hematology analyzer is manufactured in France by a manufacturer called Horiba. We first came across this device in Europe and fell in love with it right away because it is a very accurate tool to quantify and characterize PRP and whole blood samples in really less than a minute. So in other words, the Horiba Hematology Analyzer enables practitioners, hospitals, groups that are actually quantifying whole blood samples and PRP samples at the point of care. So when we actually found this hematology analyzer, thanks to Dr. Magalon, who's joining us today, we basically started the process of making that available to our clients here in North America. So we're very, very excited to be sharing these results with you today, and even more excited to have Professor Dr. Jeremy Magalon from Marseille joining us live from France, who has been gracious enough to go through all of our hematological results that stemmed from our side-by-side analysis. And he's going to basically take you through basic PRP science today. And he will also take you through various classification systems and why we actually need, as a sort of a larger group, to start characterizing or sort of defining what it is we're injecting. We come across a number of different clients every single day across multiple specialties in medicine that basically say, I just don't know what I'm injecting in my patients. So part of our efforts and the resources that we basically poured into this side-by-side analysis is to basically shed more light on what it is that is being injected. So beyond this classification, we're going to be sharing with you the results of our side-by-side analysis and some calculations that were made to determine the X factor, the recovery rates of different cellular PRPs. And through this webinar today, I'm going to be obviously opening the floor to questions at the end of the session. So if you have any questions, please feel free to note those down in the question field in your GoToWebinar application. Beyond that, I'll be also launching different polls through the webinar today to sort of ask some questions and make this a little more interactive, and we'll be sharing the results with you on those polls. Furthermore, we actually have various handouts that have been uploaded onto the GoToWebinar portal here for your download. So these handouts are available for you to download, and basically will be referred to across this presentation today. So you'll find some marketing information as far as the Horiba Micros ES device, You'll find various journal articles on the DEPA classification that Dr. Magalon and his team published in the British Medical Journal in 2015. You also find a journal article on androgenic alopecia and the use of PRP for that indication, as well as a peer-reviewed article that was just published in the Prime Journal in July of this year, relating to dermal rejuvenation and PRP, or specifically EmCyte PurePRP. So again, I thank you very much for your attendance today. I hope you can hear us well and clearly. I'm going to sort of turn the presentation to Dr. Magalon, who's coming to us live from Marseille today. So Dr. Magalon, welcome. Thank you for joining us.
Okay, thank you, Joanne. Thank you for this invitation. So today I will make a short presentation about the quality control analysis from the Joanne workshop, where she compared the biological characteristic of PRP from different devices for aesthetic purpose. So next slide. As you know, in blood you have a majority of red blood cells, which represent more or less 94% of the cells. Leukocytes are only 0.2 to 0.5% of the cells. And what you can see on this picture, the small cells, only 2 to 3 microns, surrounded by a red circle, are the platelets, which represents 5 to 6% of the cell component from the initial blood. These platelets, and we are here today to speak about that, they have raised a huge interest in regenerative medicine, because they have inside the alpha granule a huge content in growth factor. These growth factors, they are involved in angiogenesis, in collagen production through, I would like to come back to the previous slide, Joanne. In angiogenesis through VEGF, in fibroblast proliferation and collagen production through EGF or TGF-beta, or also with PDGF to extracellular matrix development. These platelets, they are able to release their growth factor once they are activated through calcium or collagen. Next. The first surgeon that used PRP for its regenerative property was Robert Marks. He's a maxillofacial surgeon, and he gave a very easy definition, which was that PRP is defined as a suspension of platelet in plasma characterized by a platelet concentration higher than the concentration of the original blood collected. Next. So you have a very easy definition, but when you have a look to this pioneer paper in 1998, it gives a very accurate definition, because it gives a lot of details about the preparation. It takes a very large amount of blood. He make, and we are talking about things that happened 20 years ago. He make a platelet count for each patient. He is able to say that there are approximately 0.06 nanogram of PDGF for 1 million of platelets, and he has a target increase in platelet count of 3.4-fold. Next slide. He also gives a precise definition about his target concentration, and he says that there is a scientific proof of bone and soft tissue healing when you use PRP with 1 million platelet by microliter with a final volume of 5 milliliter. So if you have 5 milliliter of PRP with a 1 million platelet by microliter, you are able to make a calculation of a total dose of platelet injected for bone and soft tissue healing in the definition of Marx. That is, that in his practice, Marx used 5 billion doses of injected platelets. Next. So you all know that the manufacturing process of PRP is simple. You just have to make the centrifugation of whole blood, and then you will have a separation of plasma and other cells, and you will have to try to recover this yellow part that contain both plasma and platelets. Next. In some case, regarding previous one, in some case regarding the device you will use, you have in the upper part of the plasma the PPP, the platelet poor plasma, and in the lower part the PRP, which is a platelet rich plasma. And some manufacturers, they recommend to remove this upper part to have a more concentrated PRP. Next. So you all know that there is a lot of different medical devices available to produce this PRP with a lot of different possibilities, some tubes, some medical device with different forms, and also this kind of device which are more automated. And next, and we know that all these different devices, they will give, and it's no, there is a lot of publication about that, they will give different biological PRP with different characteristics. Next. However, there is still one weakness in the use of PRP, and this recent publication from the team of Jorge Chala have made a huge retrospective analysis of all studies in orthopedic field using PRP, and they have shown that with more than 100 studies, only 11 give enough description to reproduce PRP preparation, and only 17, it means 16%, make a characterization of the injected PRP. Next. And what we have now in the biggest journal of sports medicine, where they are very interested in PRP, there are now a kind of consensus to say there is absolutely no consensus. And you have here some of the recent remarks from the American Journal of Sports Medicine saying that actual PRP product lacks an up-to-date characterization, and that all publication in the PRP field should require a strict characterization of the PRP content. Also in 2016, a think tank about the biological treatment for sports injury have stated that we need more study with an improved characterization of active element, with standard concentration of active molecules, leukocytes, and dosing regimen, and that we need probably to have national and international collaboration in research, and also a collaboration with governing bodies to promote scientific advancements about PRP. Next.
So Jeremy, it's basically safe to say that for those practitioners in sports medicine and orthopedics that have been using PRP for quite some time now, the general consensus is that we need to start characterizing and defining the injectate in more detail in order to move the science forward in sort of randomized control trial settings. Given that this webinar here is really comparing aesthetic PRP systems, it's pretty safe to say that on the sort of dermatology and plastic surgery side of things, the sort of the medical societies are not quite there yet with biologics and characterization. So what we're doing here today and what we've done earlier this month in comparing the systems and sort of really calling for more characterization is really groundbreaking as far as aesthetic PRP is concerned.
Absolutely, I absolutely agree with you. And so now we have stated that all these different devices will give different products. We have now to understand what we need to characterize PRP. What we need is to have a sample of whole blood in which you will be able to have the platelets, the leukocytes, and the red blood cells concentration. And also it's important to know the net volume of collected blood. And in your PRP, you have to know what was the volume of PRP obtained. And if you did not inject all the PRP you have obtained, you have also to know the volume of PRP you inject. And on this PRP sample, you can also, thanks to the hemocytometer, to have the platelets, the leukocytes, and the red blood cells concentration. And thanks to these 8 parameters, next slide, you are able to give a lot of characteristics about your PRP. You can make the calculation about the increase factor in platelets and leukocytes. You can give to a patient the dose of injected platelets, which is simply the multiplication of the platelet concentration by the volume. You can give also a relative composition of your PRP. What was the percentage of platelets compared to leukocytes compared to red blood cells? Also, is the device you are using efficient? It means you have to calculate the platelets recovery rate. It means when you have 100 platelets in the blood, what was the percentage of platelets you recover in the PRP? And with all these parameters, there is no a lot of different classification of the PRP. We'll be able to use one of these classification, and I will detail later the publication the classification we use in Marseille. So to do all that, we have a software in Marseille which is called the RePrep software, where you can put all the information about the patient ID. Next. The indications, birth date. Then you will put on the left the characteristics of the blood you have sampled, and on the right the characteristics, the biological characteristic of the PRP you just obtained after centrifugation. Next. And then you have also information about the injection you have to fulfill. All these 3 steps, they take less than 1 minute, and you can switch to the next one. And thanks to that, we're able to print this kind of report where we have, and we can give this report to the patient. You can switch to the next one, where you have patient ID, next, how was made the PRP preparation, and the most important, all the detail about the injection. In this case, we have injected 5 milliliter of PRP, which contains previous one, which contains 3.5 billion of platelets, only 0.1 billion of red blood cells, 1.8 million of leukocytes. It was a very pure PRP because we have more than 95% of injected platelets. And you can see the device that we have used was efficient because we have a good recovery rate above 70%. Next. So that's why in our public hospital now we are using PRP in daily use in 2 different hospitals. One, we are directly in the radiology department. We are mainly doing orthopedics. And we don't have any lab in this hospital, so we have a small counter, and we treat tendinitis, arthrosis, degenerative meniscus. And we have a second hospital where we have a lab, a hematology lab, that makes all this quality control, and where we treat patients for arthrosis and alopecia. Systematically, we do the injection report that I just shown to you. And when we have more PRP than needed, we make an activation step. We freeze the PRP just for future quantification of growth factor. Next. So to alert about the big difference in the PRP device, in the past we have done the same kind of workshops that Joan just did. It was in last January in the PRP industry session of IMCAS Congress. I've given my blood, and then we have next. we have prepared PRP with maybe 5 or 6 different PRP, and I won't show you these results today, but I just show you the macroscopic aspect, and as you can see, all these PRPs, they have a completely different color, and you can imagine that they have completely different biological characteristics. Next.
So we're going to stop right here and take a quick poll for those of you that are attending. So at the moment, if you can answer the poll, are you using PRP today in your practice or hospital or surgery center setting? We're going to publish these results after the webinar today, but we just wanted to kind of get a feel for where you are at in the use of PRP. So I'm going to close this poll. Thank you for your responses. We got 78% of our attendees using PRP today and 22% not using PRP today. Excellent.
Okay, I can go, Joanne?
Yes.
Yeah. So now let's go to the comparison and the workshops that Joanne performed. So the 4th of October. So you have here. Sorry. So you have here some picture of the workshop and what was done. One single donor gave his blood, and 6 PRP preparations were made with Magellan, Selphyl, Eclipse PRP, EmCyte with 2 different devices, the gold one and the pure one, and Regenlab. A complete cell count was performed thanks to the Micros ES60, and the initial blood was quantified with the EmCyte syringe. And then you have here on this picture the aspect of all the PRP obtained. You can just notice that, for example, more or less they are all yellow to orange, but only the Magellan device, you can guess that he has a higher contamination in red blood cells. Next.
So I'm going to launch a second poll now, which basically asks the questions of the 78% of attendees that are using PRP today. Which system are you currently using in your clinic, hospital, or surgery center? So again, given that this webinar was sort of predominantly focused on aesthetic PRP, we really did look to compare PRP systems that are available in the specific markets. Selphyl, Eclipse, Regenlab are not that active in orthopedics and MSK, and we plan to sort of follow this webinar with a deeper dive into orthopedics and MSK kits as well. So we're just going to close this poll. We got 17% of attendees using Selphyl, 25% using Eclipse, 75% using EmCyte today, and 8% using Regenlab. Interestingly, nobody using Magellan on this call today. All right.
Okay, next slide. So I won't go in detail to show that, but when you use the Micros, you have this kind of small tickets, and you have here all the tickets from whole blood and from all the PRP. Next. So first things regarding the blood, the quantity of blood harvested by each device is different, and you can see with Magellan and EmCyte Pure, you have to harvest 26 and 27 cc of blood and you have to add 3 and 4 cc of anticoagulant. You can see that with Regenlab, which is a tube, you have only 8 ml to harvest. I think, Joanne, you could confirm that with Selphyl and Eclipse, you have harvest 2 tubes for each of them, no?
For Selphyl, for Selphyl, we had 2 tubes. So basically 2 9 ml tubes of anticoagulated blood for a total of 18. The Eclipse kit that we used was their high density or 22 ml tube. So it's a larger tube, and you'll get to see our exact process in our behind the scenes video, which will accompany the recording from this webinar.
Okay. So next, you have here the initial cell count from the patient, 191 platelets, 4.8 terabyte of red blood cells, and 7 gigabyte of leukocytes. Next. So regarding the PRP, first point, what was the volume we obtained? You can see that more or less we obtained between 5.5 to 7 milliliter of PRP. The only exception was Regenlab, where with only 9 ml tube, we get 4 ml of PRP. Then when you have a look to the concentration, you can see that Regenlab, Eclipse, and Selphyl, they get smaller increase in platelet concentration compared to Magellan, EmCyte Gold, and EmCyte Pure. EmCyte Pure was able to get a concentration higher than 1000 gigabyte liter. And regarding red blood cells and leukocytes, you can see that from Selphyl, Eclipse, EmCyte, both of them, and Regenlab, there are very few contamination, and we will come back to that later. Whereas with Magellan, you have large contamination in red blood cells, because you have to have in mind that red blood cells, the unit is terabyte. It means that if you want to have that in gigabyte, you have to make a multiplication by 1000. So more or less you have same amount of platelet and red blood cells, and you have also large contamination in leukocytes compared to other devices. Next. So basically, with this first element, you are able to calculate what we call the increase factor in platelets and leukocytes, which is the platelet concentration in PRP divided by the platelet concentration in the whole blood. And you can see that the only device that has an increase factor in leukocyte upper than 1 is the Magellan one, so it's a leukocyte-rich PRP, whereas all others are pure PRP. You can see that this increase factor in platelets vary from only 1.5 from Regenlab to 5 to more than 5 with the EmCyte Pure PRP. Next.
So for those of you that have actually looked at our white papers on our website or familiar with X factor, this is what this increased factor in platelets means. So it's the ability, or when we actually tested these PRPs, how much over baseline these systems were able to multiply baseline platelet levels. So in other words, the EmCyte Gold kit would have multiplied by 3 times the baseline platelet concentration.
So now let's go through the parameters which are for us in Marseille the most important. We never use the increase factor to characterize our PRP. We prefer to talk about what was the total dose of platelets we have delivered to our patient. And you can see that it's interesting that it can vary from only 1.1 billion to 6 with Regenlab to 6 billion with EmCyte Pure. It's important to have in mind that this parameter is directly correlated to the amount of blood you have collected. If you collect more blood, it's normal that you are able to inject a higher dose of platelet, and you can see that it's the case with Magellan and EmCyte. You have harvested with the anticoagulant 30 cc of blood, and in this case you are injected 4.5 for Magellan and 6 billion of platelet. With Regenlab you have injected only 1.1 billion because you have harvested only 1 tube. Next. Second very important parameter for us, it's what we call the efficiency of production. So we have a look to the recovery rate in platelets. So what was the ability of my device to to recover the maximum of platelets? You can see that it varies from 55% 4.6% with Eclipse to more than 100% with the EmCyte Pure. So I will come back to that because normally that's not possible to obtain a recovery rate upper than 100%. And then last parameter, which is extremely important for us, is the purity in platelets. So we compare the amount of leukocytes, red blood cells, and platelets in our PRP. And you can see that from Selphyl to Regenlab, you have very pure PRP because you have more than 90% of platelets in the injected product. Whereas with the Magellan PRP, you have finally the same amount of platelet injected than red blood cells. And you can see that finally leukocytes, there is a hot debate about leukocytes, they are a very, very small part of the injected product because at the beginning in the blood, as I told you at the beginning of the webinar, they are only 0.2 to 0.5% of the cells.
And
Next.
why this is clinically significant is obviously because RBCs and leukocytes form part of the injectate. So we need to kind of shift our thinking away from injecting just platelets. You're injecting a cocktail of cells, and some of these cells may have a deleterious effect on the injection sites or the tissues that are being injected. More and more, we're learning that RBCs have a deleterious effect on chondral tissue, have a deleterious effect on soft tissue. So it's really important to seek PRPs that are actually pure or mitigate the amount of RBCs as much as possible. Jeremy mentioned hotly contested debates on leukocytes. So leukocytes are a sort of generally bigger family of cells. Granulocytes or neutrophils do tend to be the inflammatory white cells that we are looking to, mitigate as well for both soft tissue, dermal injections, and more sort of orthopedic intra-articular injections as well.
So with these three parameters, with the dose, with the efficiency, and with the purity, we were able to make a classification that we have recently published, which is called the DEPA classification. The last A is for the activation that I didn't mention today. And as you can see, for the dose, we make these classifications that vary from upper than 5 billion to less than 1 million with 4 letters, A, B, C, D. Regarding the recovery rate in platelets, it varies from more than 90% to less than 30% with 4 letters, A, B, C, D. And regarding the purities, the relative composition in platelets, we have also 4 letters from A, more than 90% to D, less than 30%. So you have here all the different DEPA classification. And when you are able to reach a triple A, it means you have a high dose, that your device recover the very high amount, a very high percentage of platelet, and that your PRP is extremely pure. And that's the classification we are using daily in Marseille. Next.
One thing to note about activation here, which is the A in DEPA, is that most of these commercially available kits don't sort of suggest or require activation, with the exception of Selphyl. So the Selphyl kit actually comes with a second tube, which includes calcium chloride 10%. And what that does is that it's that calcium chloride is actually a chemical activator and will force those platelets to release their alpha granules and degranulate. In other words, what we did and how we tested the Selphyl kit is obviously we actually tested the PRP that came out of the first spin or the first tube, because obviously if you expose platelets to calcium chloride, you're going to dramatically affect the platelet count, in other words.
Absolutely. So to conclude this workshop, it's a good illustration of biological heterogeneity in PRP obtained with different medical devices used for aesthetic purpose. We cannot overinterpret this result. There is no clear scientific conclusion because it was performed only on one case, but you can see that a dose could vary from 4.3-fold, from it was 1.1 to 6 billion. That the device tested get a good purity, except one device that give rise to a PRP with the same quantity of platelets and red blood cells. And also that the recovery rate can vary from more or less 50% to 100%. Regarding these points, the recovery rate above 100%, it suggests that the platelet count in the whole blood was underestimated. If we have a correct platelet count in the blood, it could modify the recovery rate, but not the platelet dose or the purity I have shown to you. If you are doing that again, it will be very important to use EDTA tube for whole blood and PRP sample, because we have shown that with this kind of tube you have a concentration in platelets that is stable until 24 hours. And this part we will publish that very soon in the open access journal of the British Medical Journal of Sports Medicine in a paper called Technical Tools for Correct PRP Quality Control. We share the opinion of Johan and of the orthopedic leaders that probably all these difference could lead to a clinical difference. Next. So to conclude this presentation, we have it's now 20 years that PRP is used in regenerative medicine. You have seen at the beginning that the initial description from Marx was very accurate and probably more accurate than current randomized clinical trial using PRP. It's a promising product, but still debated due to a lack of evidence-based medicine. And there is one big weakness, it's that we don't know what we inject. It's urgent, there is now a urgent need of guidelines for PRP use and standardization. We are trying to publish now guidelines to realize a correct PRP characterization. I think mainly for orthopedic purpose, but why not also for dermatologic purpose, that we need minimum characterization in high-level randomized clinical trial that should be defined by scientific societies. And probably we need to have collaboration between industrial, university, private practitioner, and scientific society to build these guidelines. And I like this sentence from William Deming, who is a data scientist, that says that without data, you are just another person with an opinion, and that's I think that fits perfectly to the PRP world now. Next, so thank you for your attention, and I'm now available if there is some question or debate about the presentation and the results.
First and foremost, based on what you've seen today, we'd like to know whether those of you that are attending would be interested in testing your current PRP with a hemocytometer at the care. Obviously, this adds some cost to the proposition, so we're just sort of looking to understand whether this is something that you feel for aesthetic purposes is important to do or not. That's a resounding yes for this question and this poll. As far as the questions are concerned, we're going to just time check here. We've got 20 minutes left for the allotted webinar today. I think Jeremy did an excellent job at presenting the basic science and the reasons for classifying or defining PRP. Wanted to sort of paraphrase what he had mentioned earlier about the actual tubes that were used. I'm just going to open my webcam here and show you the BD vacutainers with no additives, or the red top tubes, the serum tubes that we actually used, which unfortunately created some platelet aggregation. So based on Jeremy's feedback since October 4th side-by-side analysis, we have basically started implementing testing all of our samples, whole blood samples and PRP samples with KDTA tubes, or the lavender top tubes. And basically what that brings about seems to be a more stable characterization that can be done up to 24 hours after the sample was created. So that obviously will be taken into consideration for our orthopedic and MSK side-by-side comparison, which we plan to do the first week of November. So if those of you that are listening have some Arthrex or Harvest or selling centrifuges and kits that you're willing to sort of basically donate for the good cause of side-by-side analysis and sort of leveling the playing field and just understanding this science in more detail, please feel free to reach out to us and let us know. We have our hematology analyzer ready, and I'm sure we're going to have a lot of demand and a lot of interest in that side-by-side analysis as well. So I'd like to open the floor now to questions. Just going to try to see if I can make this a little bigger. I will address these questions. 1 second. There we go. That's much, much better. Okay. One question that came through was, how many donors do you think would take to get an accurate representation of how they perform in general? I don't know what that means specifically. I mean, obviously, we took the blood of one donor here and processed it across different commercially available systems, because that sort of baseline level would establish, would establish a nice baseline level and see how those different devices performed next to each other. Obviously, on an N of 1, we can't draw sort of overarching conclusions to all of this. But again, it was an interesting exercise to do because nobody has ever done this before. It was a very costly and very time-consuming exercise, as I'm sure you understand. Next question. Which PRP devices have a 510K clearance for aesthetic use? It's a very good question. So most and all PRP kits that are available in aesthetics today have a 510K clearance for the processing of autologous blood with or without allograft bone at the point of care. So none of the PRP devices that are available today do have a specific aesthetic use indication. So the use of these PRP kits really are sort of at the discretion of the healthcare provider, which all of you are today. So at your discretion, you're able to use the PRP kit of your choice for the indication that you choose or deem medically necessary. Next question. What independent studies do you have with EmCyte Gold and EmCyte Pure? Good question. So as far as independent white paper studies that are available on our website at plymouthmedical.com under the resource section, we typically send a lot of our competing or sort of competitors' kits as well as our kits to a third-party independent lab for them to do this type of analysis. The reason why it's important to have independent studies, obviously, is to sort of bring more gravitas and sort of impartiality to the results that are stemming from our systems or our analysis. So at the moment, the EmCyte Gold kit is really only available through Plymouth Medical. It's a product that we've just literally launched on the market. So our plan is to have independent studies published from BSR labs in Cambridge, Massachusetts shortly. So as soon as that's available, obviously we'll have that uploaded on our website for all to see. The next question that I have here is, do you have any platelet counts using hemocytometry, the gold standard for platelet counting? Yeah, the hemocytometer that we actually used for the side-by-side analysis, all of the results or those printed tickets that you saw in this presentation were taken at the point of care with these sort of BD vacutainers, unfortunately, on October 4th. So the hemocytometer that we had actually cleared for platelet rich plasma. So the gold standard for platelet counting is hemocytometry, and that's what we actually did for the side-by-side analysis. So thank you for your question there. The next question, if platelets are clumped, not activated, will the Horiba Micros system read them accurately? The Horiba counts cells by volume, right? Perhaps Dr. Magalon can answer this question, but hemocytometers basically characterize or count cells based on the size of the cells. Dr. Magalon, do you have anything else to add here about calculating platelet aggregates?
Yeah, it's not. That's a very, very good question. What we have noticed is when you have clumped in your PRP, it seems that when you put them, but we have to confirm that, in the EDTA tubes that I mentioned to you previously, then I do my platelet count with the Horiba, and then I have something which is stable during 24 hours. So it means if I have something stable during 24 hours that I do not have any more clumps until I have mixed my PRP with this EDTA anticoagulant. What is very important is to follow guidelines. We have worked a lot about that, and what we advise is for any platelet count, any whole blood count, no matter the anticoagulant you are using, citrate or ACDA, when you make sampling, use EDTA tubes, and you will have the more accurate platelet count as possible. And yes, the Horiba counts the cells by volume. It means it gives you a concentration. Yes.
Thank you, Dr. Magalon. Next question from the same person is, what disclosures do you have?
I do not have disclosure.
Thank you. Next question from a physician this time. Do you think there is an ideal dose overall, or that the ideal dose depends on the application? I.e., or an example, for an antifibrotic effect, which dose concentration would be ideal? That's a great question. Thank you, Dr. Almadori.
I'm just looking at the. Yeah, we have. Unfortunately, we have no idea about the ideal dose because that's something which is extremely recent. The fact to characterize all the PRP, and there is a lot of randomized controlled trial where people they don't know what they inject, so it completely limits the interpretation. I don't have any idea about antifibrotic effect, but what I can tell to you today is that in our experience, for example, when we do culture cartilage, then we put on this culture of cartilage of chondrocytes, we put red blood cells, PRP with white blood cells, and PRP with increased dose of platelets. We have completely different effect. And for example, we have a non-proliferative effect when we put whole blood with red blood cells, when we put PRP with leukocytes, and when we put an increased dose of platelets, we do not have the best effect with the higher dose. So I think we are at the very beginning of all that, and we need now that even if PRP is now a routine care treatment, that people know what they inject, then to gather all the data and trying to find the ideal dose for each indication we use PRP.
Yes, there definitely seems to be a dose-related response depending on which indication you're treating. I wish we were at the point where we understood specific doses for effects and this, that, and the other. Technically, what we're sort of gleaning from the literature at the moment is that soft tissue or wound care type indications seem to benefit from lower platelet doses than intra-articular applications, such as arthrosis or sort of knee osteoarthritis or mild to moderate OA. So, you know, as we sort of educate ourselves more, as practitioners tend to quality control and define their PRP injectates, their stem cell injectates as well, I think that's what's going to push the science even further. I know that a lot of the sort of other kits or test tube kits that we sort of presented here today, Eclipse, Regenlab, and Selphyl, have a relatively large market share in the aesthetic market, but and they're most likely going to be pretty peeved with what we've presented today, in the sense that the sort of the dose of platelets that seems to be elicited from these systems doesn't seem to be significant enough to elicit a response. Having said that, we're going to continue doing what we do and pushing the data forward and pushing the science forward, and you know, sort of making this type of information available for healthcare professionals. So what we sort of tried to attempt to do today is obviously make this information available to all of you. We've had several competitors sort of reach out to us and say, hey, you know, include us in your webinar and this, that, and the other. But you know, they all have access to the same devices, the same hematology analyzers, and I think it's, you know, safe to say that you know, this is definitely a first, but it's certainly not the last that you're going to see. And we're wanted to be as clear and transparent as possible. We've shared all of the data with you. We took multiple sort of data points as well, which will all be available for healthcare professionals that are registered with Plymouth Medical on our education portal. So all that's to say, I want to, you know, just being conscious of time, we've got 8 minutes left, so there's still questions pouring in here. So we're going to keep answering those. So we've got a question here from Dr. Shaluhi. Thank you for this great webinar. Is it safe to inject patients who are using certain medications like tamoxifen or other anti-cancer treatments? Any risk of cytotoxicity on tissues? Dr. Magalon, is that something that you want to answer?
Yeah, as I told you, in our hospital, we don't do a lot of we are focused on orthopedic treatments. We do a very small dermatologic indication, mainly in alopecia. I work in a public hospital, and there is still, even if there is no proof of anything, that to inject growth factor from platelet in patients with cancer, we don't know what could happen. So I have no experience in injected patients that have cancer and then that are taking anti-cancer drugs. So I have no clear answer about that. Probably I don't know if in the literature in PubMed there is some things about that, but I have no experience in that.
I think generally the contraindications for PRP are sepsis, active cancer, or thrombocytopenia. So those are sort of the three sort of major contraindications. Obviously, if patients are on NSAIDs therapy, all of these other sort of medications that can be on that have an effect on platelet function will obviously affect sort of the outcome of the treatment. So thank you for that question, coming all the way from Beirut, Lebanon. Next question is from Dr. Peter Ebers. What is the definition of leukocyte-rich versus pure PRP with regards to the presence of remaining leukocytes in PRP? You state a leukocyte increase between 0.2 and 0.6 as pure PRP.
It's not my definition. It's what we find in the literature from Peter and also from Dr. Ehrenfest, that if the leukocytes if the increase factor on leukocyte is upper than 1, you have leukocyte rich PRP, whereas if it's lower than, and in our case it was between 0.2 and 0.6 in your comparison, if it's lower than 1, you have a pure PRP or leukocyte poor PRP. Both terms are used, but as I told you, we are not now in our hospital, we are not looking at purity with this parameter, and we prefer to have a look to the global composition, and we define now a pure PRP when you have more than 90% of platelets compared to red blood cells and leukocytes.
Thank you, Dr. Magalon. Now we've got 4 minutes left, and we've got another question that comes through here with regards to, yes, so could you place the initial test results up for us to see the difference? Let's see if we can do that here on the presentation by going back to those data. I think what this question is relating to is obviously the fact that there seems to have been a underestimation of platelets in the initial baseline levels. We can also see, let me try to see if I can pull that up. Jeremy, do you, Dr. Magalon, do you actually have the side-by-side results of the baseline blood?
Yeah. You have here on the left, it was the blood here. It was done at 12, the 4th of October. So it's 6.9 in leukocytes, 4.8 in red blood cells, and 191 in platelets. And then you have here Magellan, Selphyl, Eclipse, EmCyte, Pure, EmCyte Gold, and Regenlab. So the question is regarding Eclipse, if I understand well. And in Eclipse, so you have moved from 191 platelets to 328 platelets. So it was not a decrease. I don't completely understand the question. It was an increase of, I don't remember, but 1.6 or 7 fold in platelet increase.
Really a good point, because in our white paper analysis that stems from the ESR labs in Cambridge, when we actually previously tested these test tube systems, they were coming in at around 0.5 to 0.7 times baseline concentration. And what we did here, obviously, we're very familiar with, you know, the PRP that comes from Regenlab and Eclipse. Based on the comments from their chief scientific officer at the EmCyte conference in Paris last year, they made a real huge deal about the fact that there is quite a bit of platelet aggregation that happens in test tube systems. So if you could physically see the test tubes, you can see some little chunks of that gel inside the tube as well. But apparently, Eclipse and Regenlab both suffer from a great deal of platelet aggregation. Personally, I believe that happens with a lot of kits, especially if you're putting them in, you know, top vacutainers like this. But what we did here is we actually let the PRP rest. So this comment came from the chief scientific officer from Regenlab that basically stated, you really do need to get to get an accurate platelet count from these test tube systems. You do need to kind of let it rest and let the platelets disaggregate. Can you substantiate that, Dr. Magalon? Is that something that you kind of came about in your characterization last January in Paris?
Yeah, that's right. But as I told you, that's right, that when we have done this workshop in IMCAS, we get this thing that with the regen tubes, that the platelet concentration was increasing over the time. But as I told you, and that we can see macroscopically some clumps in the tube. But as I told you, I would like to do, at that time we were using plastic tubes like you do today without any additional anticoagulant. And I would be interested to do again this experiment with a EDTA coated tube, because my feeling is that it will correct the platelet count immediately without waiting.
Okay, great. Thank you so much for that. So I see that we've completed our hour for the webinar here today. I wanted to take this opportunity to thank Dr. Magalon profusely for helping us out and presenting the data in the most impartial way possible. Stay tuned for the recording of this webinar if you want to sort of pass this along to other healthcare providers and doctors that want to understand the science behind PRP in more detail. Also, as a quick reminder before we log off, you have several handouts that we've uploaded here for your use. We have Dr. Magalon's ZIPA classification. We have a study on androgenic alopecia that was done with a PRP that hovers around the 3-time baseline mark. We have some mark information on the Micros ES hematology analyzer or hemocytomer, which is cleared for PRP characterization. And then last but not least, we actually have our Prime Journal article, which features Dr. Peter Everts and Dr. Jorao's work in Portugal, looking at 3 consecutive injections of PurePRP at monthly intervals and the effect that had for dermal rejuvenation. So I hope you enjoy that reading, and I also hope you'll be in contact with us for any sort of further questions. Without further ado, thank you so much for your attention today, and I hope to see you very soon. Thank you, Dr. Magalon.
Thank you very much.